Hello and welcome to this video. I'm going to take you through resuscitation of the newborn. So this is one of the most important procedures for nurses and is regarded as one of the neonatal emergency procedures. It is therefore important for a midwife or nurse to acquire a skill and gain competence in carrying out this procedure. Let's get started. So, resuscitation of a newborn, this is a procedure performed to restore the heart and lung action when spontaneous breathing does not begin within the first minute of life. Indications for newborn resuscitation includes birth asphyxia, prematurity, and deliveries involving forceps or vacuum extraction. Additionally, resuscitation may be necessary for babies born through difficult breech deliveries, those delivered through prolonged second labor, and infants born by cesarean section. The aims of newborn resuscitation include establishing and maintaining a clear airway through effective ventilation and oxygenation, ensuring proper circulation, correcting acidosis, and preventing complications such as hypothermia, hypoglycemia, and hemorrhage. The principles of newborn resuscitation emphasizes the importance of creating a warm environment to maintain the infant's body temperature, ensuring the availability of oxygen for effective breathing, and providing adequate lighting to facilitate the procedure. Additionally, it is crucial to call for help when needed to ensure that the resuscitation process is carried out effectively and safely. The requirements for newborn resuscitation includes a binaural stethoscope, an endotracheal tube introducer, and syringes of various sizes, which are the 1 ml, 2 ml, 5 ml, and the 20 ml, accompanied by needles of sizes 21, 23, and 25G. Additionally, cord clamps, warmed dry towels, and adhesive tapes for tube fixation are essential components of the resuscitation kit. Other requirements include a neonatal ambu bag along with face masks of various sizes. Additionally, naloxone hydrochloride is necessary as an antidote for morphine or pethidine if these drugs were administered during labor within 4 hours before delivery. So the recommended dosage of naloxone is 0.01 milligrams per kg of body weight. Newborn resuscitation requires specific medications to effectively stimulate heart muscle activity and address acidosis. Adrenaline in 1 to 1000 ampules is used to stimulate the heart, with a recommended dosage of 0.1 ml per kg body weight. Additionally, sodium bicarbonate in 4% ampules is administered to combat respiratory and metabolic acidosis, with a dosage of 1 ml per kg of body weight given IV. Other key interventions that are needed is administration of dextrose at a concentration of 25% to 50% to treat hypoglycemia. Vitamin K is given to prevent bleeding disorders, while normal saline or Ringer's lactate is used for rehydration or volume expansion with a recommended volume of 100 to 250 ml. Additionally, a dose of 1 ml of vitamin K is typically administered intramuscular. Let us now discuss the steps in resuscitation. We're going to start by looking at the steps involved in mild and moderate asphyxia. Okay, so after noting the time of birth, the umbilical cord should be clamped and cut. It's essential to provide warmth for the newborn by wrapping them in a warm towel and immediately drying them from head to toe. This drying process also stimulates the baby's breathing. If the baby begins breathing on their own. After drying, no further stimulation is necessary. Providing warmth is essential to prevent hypothermia, which can lead to increased metabolism, increased oxygen requirements, and metabolic acidosis in newborns. To avoid these complications, it's important to keep the baby dry and warm immediately after birth. Skin-to-skin contact with the mother is an effective method to maintain the baby's body temperature, ensuring warmth and promoting bonding. If the baby does not begin breathing after initial stimulation, clear the airway using a mucus extractor with short, sharp suctions. This helps prevent the inhalation of mucus during the baby's first gasp and allows them to take in air. In most cases, this will prompt breathing. If the baby still isn't breathing, further stimulate them by drying again and gently flicking the soles of their feet. This additional stimulation should encourage the baby to start breathing. So this is a diagram showing clearing of the airway using a mucus extractor. So you start first with the mouth and then the nose later. Okay, so you're using a mucus extractor and make sure that you're using short, sharp sucks. Okay. To ensure the baby stays warm, replace the wet towel with a warm, dry towel, wrapping it loosely yet snugly around the infant. It's important to keep the baby comfortable during this process. Afterward, present the baby to the mother for sex identification and gently explain the infant will be taken to the resuscitator for further assistance, as the baby did not cry at birth. Transfer the baby to a preheated resuscitator, positioning them on their back with the head slightly lower and extended to facilitate the free flow of any secretions. To maintain this posture, place a rolled towel or sheet under the baby's shoulder, elevating them by about a quarter to half an inch from the mattress. If the baby exhibits excessive frothiness, you may carefully position them head down for a few minutes to help clear the airway. So this is how a resuscitator looks like. So this is a resuscitator. Okay. To ensure the baby's airway is clear, gently sanction it using a soft catheter. If stimulating the baby and clearing the airway do not lead to adequate respiration, administer 100% oxygen through a face mask while continuing to provide gentle stimulation. Once the APGAR score improves to 7, hand the baby back to the mother and assist in placing the baby in skin-to-skin contact with her to provide warmth and comfort. If after 30 seconds of administering oxygen, the baby remains unresponsive and is not breathing, artificial respiration must be initiated. In cases where the mother received pethidine within 3 hours of delivery, neonatal naloxone at a dosage of 0.01 milligrams per kg can be administered either through IV or IM. Should the baby fail to show any signs of responsiveness within 1 minute of treatment, it will be necessary to provide some form of artificial ventilation to ensure adequate breathing. The newborn's condition will be closely monitored using the APGAR score at intervals of 1 minute, 5 minutes, and then every 30 minutes for the first hour, followed by hourly checks and subsequently 4 hours until discharge. The infant's temperature should be maintained between 36.5 degrees Celsius and 37.4 degrees Celsius to prevent hypothermia. Therefore, skin-to-skin contact is recommended to keep the baby warm. To avoid hypoglycemia, it is essential to ensure that the baby is breastfeeding effectively. Gentle handling is crucial, emphasizing a calm and quiet environment to promote the baby's comfort. Additionally, the baby's head and shoulders should be slightly elevated to support their well-being. Let's now discuss the resuscitation steps in severe asphyxia. Okay, we're just from discussing the steps of mild and moderate asphyxia. Now let's look at severe asphyxia. So when it comes to resuscitating an infant, there are 4 crucial steps that can save a life, commonly referred to as the ABCs of resuscitation. The first step, A, which is for airway, involves ensuring that the infant's airway is clear and opening. The next B, for breathing, emphasizes the importance of providing adequate ventilation to restore normal breathing. The third step, C, is for cardiac function, focuses on assessing and supporting the infant's heart rate and circulation. And lastly, S, for shock, addresses the need to recognize and manage signs of shock to stabilize the infant's condition. So together, these steps form a comprehensive approach to effective infant resuscitation. At the time of birth, it is crucial to ensure the baby's airway is clear. First, lay the baby on a flat surface, positioning them on their back with their necks slightly extended. This can be achieved by placing a rolled towel or sheet under the shoulders, elevating them about 3/4 to 1 inch off the mattress. Next, use a bulb syringe or mechanical suctioning to clear the mouth and nose of any obstructions. If the meconium is present, be sure to suction the pharynx, which is the back of the throat, as well. Start with the mouth to prevent any risk of aspiration should the infant gasp during nasal suctioning. So after ensuring that the airway is open, we need to initiate breathing. So we do this by tactile stimulation. This refers to the process of encouraging breathing in newborns through physical touch. This is done by drying the infant, suctioning the oropharynx, rubbing the back, and flicking the feet. In many cases, these actions help induce respiration. If the baby's breathing remains inadequate, further stimulation can be provided by flicking the soles of the feet and rubbing the back. If the infant remains apneic, positive pressure ventilation, which is PPV, should be initiated using an ambubag. First, position the baby in a sniffing position with the neck slightly extended to ensure an open airway. Place the mask securely on the baby's face, making sure it forms a tight seal around the chin, mouth, and nose. Gently compress the ambubag, ensuring the chest expands with each ventilation. So this is a diagram showing artificial ventilation with an ambubag. So on this diagram, you can see that the neck is slightly extended. Then the mask has been secured on the baby's face. You can see that the chin, the nose, and the mouth, they've been secured with the mask. So once this is done, you need to gently press this ambubag and then start noticing the rising and falling of the chest. So ventilation should be performed at a rate of 40 to 60 breaths per minute, with mouth-to-mouth breathing no longer recommended due to the risk of HIV transmission. If ventilation fails, intubation with an endotracheal tube should be carried out, allowing connection to a resuscitator for further intervention. So this diagram that we have is sniffing position, which helps us to intubate the infant. So the correct way is that the neck should be slightly extended, not hyperextended like this diagram, and not under extended like this one. So let it be just slightly extended. Okay, so this is how it should be done, the sniffing position. So once the infant is in a sniffing position, you can easily intubate. Okay. The sniffing position with the neck flexed and the head extended is considered the standard because it enhances glottic visualization and structurally aids in maintaining the passive pharyngeal airway. The baby's response to ventilation can be observed through several signs, including an improvement in color from blue to pink, better respirations, and an increase in heart rate to over 100 beats per minute. If oxygen is available, it should be administered. After the infant has received 15 to 30 seconds of ventilation and 100% oxygen, the heart rate should be checked. If the heart rate is 100 beats per minute or above, provide tactile stimulation and monitor the heart rate, respiration, and color. If the infant is not breathing or gasping, continue ventilation. If the heart rate is above 80 beats per minute, begin chest compressions. If an infant does not breathe despite positive pressure ventilation, or if the heart rate remains below 80 beats per minute, external cardiac massage should be performed using 2 fingers. Chest compressions are essential to enhance circulation and ensure adequate oxygen delivery to vital organs. It is crucial that these compressions are accompanied by ventilation with 100% oxygen, allowing the blood circulated during the compressions to be properly oxygenated. Chest compressions during cardiopulmonary resuscitation can be performed using either the thumb technique or the 2-finger technique, with pressure applied to the lower third of the sternum, depressing it by half to 3/4 of an inch. It is recommended to deliver approximately 90 chest compressions per minute, with 1 ventilation provided after every 3 compressions. Therefore, in 1 minute, a total of 90 chest compressions and 30 positive ventilations should be administered. Okay, so the diagram is showing the techniques of chest compressions. We have the thumb technique there, and then we also have the 2-finger method technique. Okay. So this is another diagram showing the same techniques. So we have the finger techniques, and of course you can notice that the neck is hyperextended. Then on this other diagram, we have the thumb technique. Now on this other diagram, we also have the ventilation part. So it means once the compressions are done, the knee ventilation also has to be done. After 30 seconds of chest compressions, the heart rate is assessed. If the heart rate is less than 80 beats per minute, chest compressions and positive pressure ventilation should be continued, and medications should be initiated. However, if the heart rate exceeds 80 beats per minute, chest compressions should be discontinued and ventilation should be maintained until the heart rate rises above 100 beats per minute. Neonates who do not show improvement with ventilation and chest compression may require medications such as adrenaline, sodium bicarbonate, naloxone, and dopamine. These medications are administered through a catheter inserted into the umbilical vein. Sodium bicarbonate should be administered at a dose of 2 ml per kg body weight, diluted at a ratio of 1:1 with distilled water, for patients experiencing poor respiration and a slow heart rate after 5 to 6 minutes of resuscitation. Additionally, volume expanders like Linger's lactate or 0.9% normal saline are recommended to treat shock, which is characterized by cyanosis and absence of pulse. To prevent hypothermia in the baby, ensure that they are warm and dry. Start by thoroughly drying the baby, then wrap them in a blanket or place them under a radiant warmer. Skin-to-skin contact with the mother is also an effective way to warm the baby. Once the infant begins breathing, they are transferred to a special baby care unit for observation. However, if there are no signs of life after 10 minutes of continuous and adequate resuscitation, it's important to consider stopping the effort. In cases where the APGAR score remains below 3 after 20 minutes, the risk of death and severe brain damage becomes extremely high, and continuing resuscitation may no longer be justifiable.